All right, today you are the doctor. You're stepping into the shoes of a medical detective, and we've got two fascinating clinical cases for you. Each one is centered on a different type of wound, and your job is to piece together the clues and make the right call.
And I'm not kidding. For each case, we're going to lay out the patient's history, their symptoms, and the lab results. And then you'll face the exact same choice a real doctor would. So, you ready to put that clinical brain of yours to the test? Let's do this.
So here's our game plan. We'll start with the two big puzzles. Then, we'll dig into case 1, lay out the problem, and then of course reveal the solution. After that, we'll tackle case 2, which is a whole different beast. And finally, we'll wrap it all up with the key takeaways that every good medical detective needs to know.
Okay, so we're looking at two very different patients with two very different wounds. One is an urgent, in-your-face problem that needs immediate action. The other, well, it's a much quieter, more chronic issue with a hidden cause. Your mission is to spot the differences and choose the right path for each one. Let's get started.
So, case number 1. This is a classic but pretty serious situation that can pop up after surgery. We're on the hunt for the telltale signs of an acute infection.
All right, let's meet our first patient. He's a 55-year-old guy 5 days out from surgery. Now, at this point, he should be feeling better, right? But he's not. He's calling in because the pain, redness, and swelling around his incision are actually getting worse. And those, my friends, are major red flags.
And when we see him in person, the story gets even clearer. The wound edges are erythematosus, that's just a fancy medical word for red and angry looking. The area is tender to the touch, but the real giveaway? That purulent discharge. Yep, that means there's pus. On top of all that, he's got a fever and his heart rate is up. His body is definitely in battle mode.
Now let's look at the blood work. These are our clues from the inside. His white blood cell count, the WBC, is way up. His C-reactive protein, or CRP, which is another marker for inflammation, is also way higher than it should be. These numbers are basically screaming what the physical exam was whispering. But one number, in particular, is the star of this show.
Let's just zero in on that white blood cell count, 14.8. You can see the normal range tops out around 11. This isn't a subtle hint, folks. This is the body's fire alarm blaring, signaling a serious infection and telling us that its internal army is working overtime.
So, this is it. The ball's in your court. You're the doctor standing there with all the clues in front of you. What is your very first move? Do you blast him with IV antibiotics, rush him back to the operating room, or is there something else you need to do first? Think about it. What's your call?
Okay, you made your choice. Time for the big reveal. The right answer here isn't just about this one patient. It's about a fundamental rule, a core principle for how we manage infections just like this one. And the correct answer is C. The absolute most critical first step is to open that wound, let the pus drain out, and send a sample of it to the lab. So why? Why is that the number one priority? It all comes down to one key principle: source control. Think of it this way. That collection of pus is like a fortress for bacteria. If you just start pumping in antibiotics, it's like you're attacking a castle without ever lowering the drawbridge. It just won't work well. You have to drain the source, get rid of the fortress first. That clears the battlefield so the antibiotics can actually do their job. Plus, culturing the pus tells you exactly which bad guy you're fighting.
And this really shows you why the other options were wrong. Starting antibiotics first? That's putting the cart way before the horse. Surgical debridement? That's like bringing a cannon to a knife fight. Way too aggressive for this superficial infection. And option E, closing the wound back up? Oh, that is a huge no-no. You'd just be trapping the infection inside, making everything 10 times worse.
So case 1 was all about speed and decisive action against an obvious enemy. But now we're going to shift gears completely. For our next puzzle, the wound you see is just the tip of the iceberg. The real mystery is what's going on deep beneath the surface.
All right, let's meet our second patient. We are moving from a sudden fiery infection to a quiet, stubborn wound that simply refuses to heal. This is a whole new ballgame.
So this is a 40-year-old woman, and we know she has diabetes. She's had this ulcer on the sole of her foot for 2 whole months. Now notice the difference from our last case. No redness, no swelling, no pus. It's just there, pale. But here it is, maybe the most important clue of all. She has diminished sensation there. She can't really feel things properly in that part of her foot.
Her lab work tells a completely different story too. Her white blood cell count? Totally normal. No sign of a big infection.
The swab from the wound, no bacteria grew. And her ankle brachial index, a test that checks blood flow to her legs, is also normal. So it's not an active infection, and it's not a blood flow problem. But just look at that HbA1c.
This number right here is our smoking gun, 9.2%. An HbA1c test is like a history book of your blood sugar for the past few months. Normal is under 5.7%, so 9.2 is dangerously high. This isn't just a bad day. This tells us her diabetes has been out of control for a long time. This is our biggest clue.
So with all that in your pocket, what's the real villain here? What is the root cause of this non-healing ulcer? Is it a problem with her veins, her arteries, or is it something directly related to that long-term high blood sugar? What's your diagnosis, Doc?
All right, let's crack this second case. And remember, with a chronic wound like this, finding the underlying cause is absolutely everything. It's the only way to actually heal the patient, not just put a bandage on the problem.
And the right call is C, diabetic neuropathy. This is a textbook presentation of what we call a neuropathic ulcer, and it's a really serious complication of diabetics.
Remember that sky-high HbA1c? That's the cause. For years, all that extra sugar in her blood has been acting like sandpaper on her nerves, especially in her feet. It literally wears them down, and that's what we call diabetic neuropathy. She loses the gift of pain, that protective sensation, so she could step on a small pebble or get a blister from a new shoe and not even feel it. That tiny, unfelt injury just breaks down over time and becomes this chronic, non-healing ulcer.
And we can knock out the other suspects pretty easily. Venous ulcers, they usually show up on the ankle, not the sole of the foot. Arterial ulcers? Well, we know her blood flow is fine, and besides, those are incredibly painful. And a pressure ulcer? While possible, the location combined with her total loss of sensation points directly to neuropathy as the main culprit.
So we've solved both puzzles. We've figured out what to do and what was going on. But what are the big picture lessons here? Let's boil it all down to two simple, powerful rules you can take with you. Here they are. Rule number 1. For an acute infection, your mantra is attack the source. You have to drain that pus first. Rule number 2. For a chronic wound, your mantra is uncover the cause. You have to look past the hole in the skin and figure out the systemic problem that's causing it, like her out-of-control diabetes. Both rules are equally important for saving a patient's limb or even their life.
And that really brings us to our final big idea. A wound is almost never just skin deep. More often than not, it's a window. It gives you a direct, unfiltered look into the patient's overall health, whether that's a raging infection or a chronic disease that's been doing damage for years.
So you did it. You navigated 2 tricky medical cases and made the right calls. But the real question is, how does this change your perspective? The next time you see a simple cut or a sore that just isn't healing, will you wonder about the hidden story it might be trying to tell? Because that is the heart of being a medical detective.